So we are on week 5. We're almost halfway there, guys. I've gotten some people giving me what they want to do for their pediatric assessment project. I've got some that are really going to challenge me I've never seen before. So thank you for trying to figure out these things that I haven't. I like to learn, and sometimes getting these off the wall things make you think because nobody's really ever gone through and analyzed and done an assessment. So you win, I win, we all win. So I actually look forward to them, and it's a lot of work for me, but I enjoy it. Again, if you give me anything on that, you can send it through your grade book, okay, through the module. You can repeat and repeat and resend. That's the way I have it set up. But let me know. I'll grade it early. And if there's like little tweaks that could make that grade a perfect 100, I'm going to let you do that. You can resubmit until you get the grade you want. Now, why do I do that? And Dr. Brown knows what I do. It's because you all, many of you, are going to be going on in your education. When you get to your BSN, MSN, PhD, it's all papers. It is all writing. It is all projects. So if I can help you the first project through, I'm helping you with your first BSN project, your first MSN project to show you what it should look like. So I'm just helping you for your future. And then me, as maybe you're going to be my practitioner, taking care of me. So I'm just helping you for your future. So let's go ahead. Any questions? Anaya and Letitia, both come on camera, please, for me. Anaya, are you there, my dear?
I was there. I was
There you.
using the bathroom.
Oh, it's okay. No worries. We don't ask you if it's number 1 or number 2, right? I'm teasing. I'm really teasing. Okay, so let's go ahead and we start off with respiratory first. So we know heart and lungs are adults and they are children. Now, adults, they're very simple, what we look for things, but in children, there's these little key things that are differences. I'll give you one quick example. Get an infant in respiratory distress. What are they going to look like? Well, when they're in severe respiratory distress, their their nares are going to be flaring. So it's nasal flaring, and it's obvious. The other thing is a grunt at the end of the breath. So it's like, uh, and they're bobbing. You hear an infant grunting, nasal flaring. This is a child that's about to crash and burn on you. This is get the intubation tray ready. Okay. So that's just one example showing you the difference adult and children. So respiratory infections basically are mostly virus. Okay. There are viral pneumonias. And how do we treat a viral pneumonia? Just like a virus, fluids, antipyretics, and rest, right? 3 things: fluids, antipyretics, and rest. Whether it's any sort of virus, that's the way the treatment will be. Now, we know most pneumonias usually are bacterial, and many times we will treat them as a bacterial. And of course, they will get antibiotics. One of the best ones is augmentin, amoxicillin, right? First line penicillin usually is what they order on these children. Now, RSV. RSV is a common cold for you and me. But in infants, we give it this fancy name, respiratory syncytial virus. Uh-oh, it's a virus again. So how do we treat it? We treat it with rest, fluids, antipyretics. Now, the problem with RSV, the smaller that we get, is the little small passages and airways that are in our head, right? We've got little short tubes open. We've got these, mucus that's dripping. We can't blow it out as well. Also, infants are obligatory nose breathers. So give a kid a cold, extra mucus in the nose, which is what RSV is. You can't suck, swallow, and breathe. So therefore, they go into respiratory distress, just trying to get their food. Now, RSV for me and you is no big deal. But infants, especially if they have some pre-existing condition, like they were premature, they have respiratory issues, they're cardiac, there's cystic fibrosis, there's some autoimmune something, you give them RSV, it could put them over the edge with respiratory distress. So we can prevent it. There's another slide I'll tell you about, but there is an immunization, but it is only the first year of life, and it is monthly from early winter to early spring. And that helps prevent this virus because sucking, swallowing, and breathing is hard enough. Then put another condition on top of that, and then clog that airway up, and that child's going to be struggling, okay? Now, let's look at the infant. The infant, when they're born, are given mommy's antibodies, right? You're born with at least something to help protect you from these big bad germs out there in the environment. Now, for the first 3 months, we're pretty well covered. After that, what happens? Well, blood cells die. I mean, they don't live forever. So mommy's blood cells start dying off, the hemoglobin hematocrit starts getting lower, you know, and now we are starting to get 2 months, 4 months, 6 months. We're getting immunizations like crazy. Why do we like load them up so quickly? It's because mommy stuff is going away by 6 months. So we really got to get all of those bad diseases covered with that immunization. Now, the first 3 months, really, a baby shouldn't be sick. In fact, in an ER, if we have a baby less than 3 months coming in with a fever, it is a red chart, high alert, get them back quick. That's how seriously we considered a infant 3 months or less with a fever. We're worried about septic shock because they do, and quickly we'll go into it. Now, from 3 to 6 months, mommy stuff is gone. Our immunizations that we've given them are not really kicked in completely. So we know infection rates are going to go up. Now, is it good or is it bad? Well, we need to get diseases in order for our body to make up the protective stuff, the antigens, the antibodies protect us against future conditions. So yes, we need them, but we need to do it in a controlled situation, right? We don't need to be sick every day. That's daycare. We know that does happen there. As we get older, we get to toddlers and preschoolers. Well, what happens with toddlers and preschoolers? What do they do all day long? They play. What do they do with the toys all day long in the play? In the mouth. And they go from my mouth to his mouth to her mouth to the other mouth. And what do children do all day long in daycare? I say they swap spit all day long and germs. But is it a bad thing again? Not really, because again, we're trying to get them good and healthy. So by the time they get to school and really need to be there and not sick, that they have some sort of immune defense against it. So just basically, we have an increased immunity as we get older because we've gotten the disease or the immunization. Now, otitis media, one of the biggest causes is actually smoking around these children. Secondhand smoke is one of the things you'll see. Ear infections, smoking, no smoking around them. Now, children's ear eustachian tubes are short, wide, and open. Think about areas of pressure, and we're going to go to this into cardiac too. You go from areas of big pressure to low pressure, right? So if you got all this mucus inside the back of the throat, and there's an escape route up these tubes, up into the ears, guess what? The mucus is going to go up there. It's like shunting up into the ears. Children are chronically getting ear infections, right? How do we treat them? Well, it's not unheard of. A kid goes into the emergency room, urgent care, doctor's office, and they have an ear infection. They're going to let you know because it is painful. Usually they come in, these poor children, holding their ear and crying. They hurt so bad. They don't want you to touch it. I try to give them a hot pack. They throw it across the room. They really hurt. So when these kids get in, what is your priority treatment? Well, we know that there's an ear problem because they're telling you, but our major priority right now is pain. because it's going to take 24, 36, 48 hours for antibiotics to work, right? But let's take the pain down, and then we can take our antibiotics, we can drink liquids, we can get the fever if they have one, pull that down, okay? And then, of course, antibiotics are your second thing we're also going to give. Now, if we're having chronic ear infections, they will put in tubes. And that tubes just helps keeping that mucus draining, preventing all that built up pressure and all that pain. And I've already said that. They're smaller and open and wide. Now, what do kids look like when they're sick? I think it's pretty obvious. Usually they're sitting in the corner, they're quiet. Usually they're sucking their thumb again. They don't want to drink their favorite juice, and they don't want to eat, they don't want to play. That's usually giving you telltale signs something's going on. Ear infections, it's going to be that pain. They have a fever. If their neck hurts, a kid with a fever is not going to eat or drink. They're not going to want to do anything. And again, if we're not drinking with a fever, we're getting dehydrated. Dehydration in children is extremely serious. So we don't want that to happen. Sometimes you might just see fever and a vomiting. That might be all you see with a child, and it's going to tell you, let's start looking. Ear infections are from all that mucus. So it's usually you hear that runny, mucusy nose. You can hear them. It's usually dripping. And if all that dripping is dripping into their trachea and causing that rhonchi and all that upper airway and all that, noisy stuff that we hear for breath sounds. How do we treat respiratory? Well, number one, you want to have them breathe easier. How do you do that? Elevate the head of the bed. Isn't that just the easiest thing? Repositioning. That will give them a really good, get the diaphragm down and let them breathe a lot easier. We know with any time a child's sick and fever infection, that rest is always going to be part of it. Children need to be taught to wash their hands, use their elbows with coughing. I think it's amazing how many children today, because of COVID, know how to put their mouth into their shoulder, into their arms. They didn't before that because they learned that big bad germ, right? And we know the biggest thing with taking care of kids is that reducing that temperature, which is also the pain, because now they feel better. When they feel better for that little bit of time while that fever is down, they're going to drink, they're going to eat, and they're going to be able to listen and get the hugs from mom and feel better that way. Now, infectious mononucleosis is a virus. We've heard about this as the kissing disease, right? Because we know it spread through mucus, right? Now, what would a child with infectious mononucleosis look like? And this is not an uncommon condition, which I'm going to describe right now. Children with mono usually go to their doctor because they're complaining of sore throat and flu-like symptoms, swollen glands, and just really feeling horrible. Okay, and it's that sore throat and those lymph nodes are, swollen, etc. So the doctor says, all right, let's do a strep, let's do a culture. Everything's negative, negative, negative. Flu's negative, everything's negative. So, okay, you are a pharyngitis or a viral sore throat. So we sent them home on rest, fluids, antipyretics. 3 days later, the kid's still sick. So they bring him back. Let's go to the urgent care this time. And they say, well, you've already done all those tests. Well, we can repeat it. Maybe it was too soon. Again, they're negative, negative again, and then they say, let's put you on antibiotics. We don't know, but just to be sure. 3 days later, you come to my ER on a Saturday morning. It's usually that way. And still, sore throat, aches and pains, fevers, antibiotics didn't do anything. So I listened to this story and I'm like, okay, we will be doing lab tests now. Why would we do lab tests now? Well, we've already proven that it wasn't a bacteria because the antibiotics didn't work, right? So we got to look for other stuff, but we got to prove it's not a viral or bacterial thing. A CBC is going to show us the white count. Is it normal? That's a viral condition, or is it elevated? That's bacterial. And then the other thing we do is what we call a mono spot test. If there's mono in the blood, it's going to be positive. And these children come back, all those symptoms positive. Now, I had a 9-year-old boy that I'll never forget him. Came in with his daddy, and it was on a Saturday, the third trip in. We did the labs. He was mono. He had a great physician who, which I loved working with him, and he explained everything to the patient and to the father. And I went in with discharge instructions. And the big thing with mono is all of these lymph nodes get swollen, especially the spleen and the liver. They're like a big balloon ready to burst if they're hit too hard. No contact sports. So we explained all this to this child. We explained this to the father. They needed to go back within 2 weeks to see their pediatrician, and they couldn't have PE until cleared by him. 1 week later, I am the trauma nurse, primary, which means anything that comes in, I'm the nurse that documents in charge of everything. It is this boy. 1 week after having diagnosed with mononucleosis, he was in the Everglades on an ATV with his brother, fell off the back, landed on his abdomen, came into the ER, dead on arrival. I'll never forget him. I'll never forget him. So mono is a simple thing, right? Kissing disease. Be careful. It's the swollen liver, the swollen spleen. His spleen was like a big balloon that puffed, and that was the end of him. So I tell you this story. If you can save one kid, then I've done my job, right? So again, it's all about activities protecting that abdomen. Okay, bronchitis. Ever get bronchitis where at night you can't sleep and it's this dry cough and drive you nuts and you're coughing, 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 cough? Nothing you can do helps you. Bronchitis is also known as tracheobronchitis. So it's the trachea and the bronchus are inflamed. Again, it's a virus. A virus. No antibiotics usually are needed for this, although many doctors put you on a Z-Pack just to be sure. But it is a virus. The key words: dry, hacking, non-productive cough, worse at night, no fever. So how would we treat it? Well, because of all the coughing, your chest is going to hurt from the coughing. So analgesics, acetaminophen, ibuprofen, which is also your antipyretics, and humidity. Children, sometimes we have these mist tents. It's like plastic over the top of the bed, or like shields and things we can put on them. A lot of kids don't like that. So what we tell them is sit in mom's lap and blow that mist in their face, and now they're getting that moist air. Many times children with bronchitis, the parents, or even with croup, they will bring them outside at night. The difference changing of air, actually the cool, the warm, actually helps with breathing those things. Bronchitis is just trying to get that cough stopped. So a big thing is cough suppressants. Although today they don't have a lot of the codeine cough medicines, they don't really have them out there anymore because there was so much abuse with them. So there's other choices that we have now, and lozenges, and of course the honey and tea and all those good things. Now croup is similar to bronchitis, but this is laryngotracheal bronchitis. So the larynx, the bronchus, and the trachea, all swollen up. So think about this. The trachea, which is sitting right there in the throat, gets all swollen. Air can't go in. So you hear, ah, when it gets even more swollen. So inspiratory stridor, air goes in just fine. All right? But coming out, you hear this bark, sounds just like a seal. It's a distinctive cough. You can hear this from across a grocery store. Oh, that kid's got croup. You can hear it. It's that barking. And it is right there, the larynx, the epiglottis, that area swollen off and can cover and can completely obstruct the trachea. And that would be epiglottitis that does it. Croup, again, is a virus. Many times it's the H influenza that causes it, which is one of the vaccines that we give at an early age in our children. So, laryngeal bronchitis is the most common. I mean, again, just look at the structures where it's covering all the upper airways. Again, usually it's a virus. Yes, it can be a bacterial, but most of the time it's viral, so we treat it that way. So usually you've had a cold, so you've got irritation in that area, right? You've been coughing, got mucus, and it causes this quote swelling, that inspiratory stridor. Remember, it's upper airway, so it has to be the in is the problem. I can't get it in because you can't pull it in well. You're going to see the suprasternal retractions. And of course, that barking like a seal. And as we continue and do not treat this, that decrease of air getting in, all that extra work causes increased respiratory distress. And of course, you're going to go hypoxic, which goes respiratory acidosis. And of course, you can fail. I mean, croup is the easy thing. We give one steroid shot, pill, liquid, whatever, and it helps it. But again, it's treating it, getting it done. So you didn't treat the croup. He said, it's just croup. It's fine. We put him in the shower. It gets a little better. That steam helped him. And now all of a sudden, this child is in severe, severe medical emergency. Think about the epiglottis. It is a leaf-like structure that covers the end of the trachea when you swallow. So food or liquid doesn't go in your lungs, right? Epiglottitis is that structure is swollen, covering the trachea. Air can't go in the lungs. There might be a little piece of something air. This is that old lady, old man, that COPD or tripod position going over, trying to find a place where he can hold his head to get air in there. That is epiglottitis. You can't swallow, you can't talk, you're drooling, you're talking like that. Again, inspiratory stridor and restless. What is your immediate responsibility for that patient as they're put into that emergency room or whatever? You're airway. And it could be intubation if you can find it, to get past that epiglottis, or it might be a tracheostomy. I've never had to do a tracheostomy at bedside. Usually we do some racemic epi aerosols, it decreases the swelling, and we've been okay. But I've never had to in all my years. So, management, airway, right? What's the first thing we do? We position them in a way that they can breathe easier, sitting them up. Young children that are frustrated and restless and anxious and angry, sit them in the mother's lap, sitting up. They can give an aerosol, whatever it is to help that child calm to get the aerosol, which is the medicine they need. We need to make sure that we keep them hydrated. If they're in severe respiratory distress, we do not feed. We do not give anything to any patient. If you can't breathe, you're not going to eat. So that child, that adult, is going to have an IV. Again, it's that nebulized mist, whether it's in the bed or sitting on mommy's lap, getting a balloon in their face. They work well. And we're going to be giving nebulized treatments, the albuterol, the rescue one, of course, but they do have something called racemic epinephrine. And it's actually epinephrine. It's the tiny little 0.5 mLs. It's not hardly anything. And it goes in a mist. So it goes directly back and it goes into epiglottis and helps the swelling to go down. And of course, steroids. Steroids are going to be given again, swelling. So RSV, as I said, it's a virus. The other name is called bronchiolitis. The bronchioles get all inflamed and gets all touching and gets this mucus coming up there. So low-grade fevers, this child is going to be having mucus, respiratory distress, worse when they're infants. For me and you, it's a common cold. We blow our nose, take acetaminophen, and we're happy. Infants, no, not always. So again, we're going to be giving the immunization. We're going to be giving it monthly from winter to early spring, monthly. okay? And it's called Synagis or palvizumab. It's a biologic, okay? And it does work. Another thing we can get for RSV is riboflavin. It's an aerosol. It's another one of those things that I haven't mentioned it here. Okay, kids, how many of you have had your tonsils taken out? Probably over half of you. Your children, probably many of you. Um, Tonsillectomies are given to children with chronic sore throats, and they can't keep ahead of them. So get rid of them so that we can prevent these infections. So many a times these children are brought into the hospital, have their surgery, and are sent home. So it's the nurse's responsibility to make sure that parent is well informed, has great discharge instructions to take care of them. So no irritating or highly seasoned food. Can you imagine the back of your throat? They've taken these big 2 chunks of tissue and cut them off right at the area and cauterized it. So it's these big scabs. They hurt. They're open, all right? So put lemon in there, put hot sauce, spicy stuff. It's going to hurt. So we don't want that. Another thing is we need to protect the scab to protect it from bleeding. Okay, so no gargling, vigorous toothbrushing, nothing in the mouth. As a nurse, you're not going to be putting a tongue depressor in there looking around. You could create more bleeding in there. No straws, right? We're not going to do that. Older children will tolerate an ice collar. Younger kids throw it off. They don't understand it. It's cold. They don't want it. But it does. Ice does help their well. Again, these children are going to be resting for a little while, usually a week, 10 days before they'll go back to school. And then this is something that older kids, because usually it's the younger kids that we do tonsils and adenoidectomies on, but older kids, their eustachian tubes get clogged. It's like going up in an airplane and they hurt. Like in an airplane, you would chew gum to help your ears pop, right? We do that actually for tonsils, and it does work, all right? Now, you're asking me why I'm so concerned about bleeding and protecting the airway. I'll give you another story. I think the girl was 7 years old. She had just gone to her follow-up visit for her tonsils and adenoidectomy. And on the way home, she vomited and vomited a big liver piece of clot of blood. They were close to the ER. They come in, of course, into my ER room, and I get a bucket, and this girl is vomiting buckets of blood. She went pale. She went limp. I had to pick her up, bring her into the trauma room, and give her a whole liter of normal saline. That was 1 week post tonsils. So, yes, tonsils can bleed, and it can be very, very scary. Pneumonias, there's all type, right? I've already mentioned viral, right? How do we treat virus? Rest, fluids, antipyretics. That's it. There's other sort of pneumonias where they're consolidated, bacterial, could be inhaled, or it could be systemic where it's gone from blood into the lungs, etc. So bacterial, viral, mycoplasma, pneumococcal, and we know we now have that vaccine, which pneumococcal pneumonia is they get very sick on it. Aspiration pneumonia, years ago, even in the newborn ICUs, we had baby powder. And we realized that baby powder and the aspiration and the powder in the air wasn't a good thing. I mean, we've learned a lot in the years that I've been a nurse and really have improved medical care like crazy. So again, powder is one thing we wouldn't have there. Another thing is when we are feeding these infants, many children have these little spit ups, right? Regurge type thing. So what they say is, children with these feeding problems, to feed them slower, burp them regularly, and having them sit up, and don't overfeed them. It's better small, more frequent meals than to try to feed them too much and they just vomit. And that will help decrease the incidence of aspiration because they're not vomiting. Children put everything in their mouth, right? What do you think is the most popular coin that a child that I've seen the most coins in their tracheas? You know what size? The quarter, not the dime, not the penny, the quarter, the biggest one. And the funny part is last year, my 10-year-old grandson swallowed a quarter and it got stuck. And he actually had to go get surgery for it because it was stuck. But we know children, you get a kid, they've swallowed it, and they're telling you it hurts. I feel it, it's there. Take an x ray, and it looks just like that. It's usually stuck right there, by your clavicles, right there. What is your nursing care? Well, are they breathing? And if they're breathing, you're okay. Do you know how they take this out? Now, years ago, they'd send them to the OR and they would do bronchoscopy with little claws, go down and pick it out. I was shocked when I saw this the first time. The surgeon comes down, leaves the family in the room, and they put the child on the surgeon's lap with the mother next to them holding their hand. They put a Foley catheter down the mouth, down below the coin, blow up that balloon. They lean the kid forward and they say cough and they pull it. They cough and vomit and it comes out. Do you know what I do? I said, you're going to spit up your coin now. Whoever gets it first gets to keep it, and I want it first. So what happens? The kid forgets about what's going on. He's focused on getting that coin, and he's on that floor getting it before me. And I'm like, oh, you cheated. You were closer than me. You got it. And it was not a big deal. Again, playing with children really, really works, right? I've seen all things swallowed. Probably the one thing that was the worst and like I didn't understand, it was a French fry. Got stuck in a trachea, and actually that child ended up on ECMO, which is heart lung machine, from an aspiration of a French fry. So yeah, I've seen a few things. Pertussis. Pertussis used to be not around, but we know there are children who do not get immunized for whatever reason, the parents, religious, personal, whatever. I mean, that's their choice, but it increases the risk for people like me, immunosuppressed, to get pertussis. Extremely, extremely contagious, respiratory, airborne, in the air. And we treat this with azithromycin, and they are placed on that good old airborne isolation. Smoke inhalation. This happens a lot in the winter with, your fireplaces. We actually saw it down in Florida during hurricanes where they're trying to build a fire to eat in the house. Things have happened. Again, how do we treat it? 100% O2. 100% O2. Tobacco smoke, I've already mentioned this. This is bad on children before they're born and after they're born. It just shouldn't be. If you want to smoke, go outside, right? Now, cystic fibrosis is pretty well hit on your exam, okay? Cystic fibrosis is an inherited disease, and it comes from two parents having the trait can give the child, just like sickle cell, 25%. It's the same sort of relationship there. Sickle cell is mucus that clogs the lungs and clogs the small intestines. It has to do with nutrition, has to do with breathing. So, what would you see with these kids? Now, if we didn't know that this kid had a possibility of cystic fibrosis at birth, do you know what symptom you would see? No stool. Usually babies are born and they're stooling right away, right? Meconium stool comes out pretty quick. With a child with cystic fibrosis or even hypothyroidism, they don't have stools right away, and it could be 2 or 3 days later. And when we see that, we'll be doing something called a sweat test. Now, why do we do sweat tests? It's because cystic fibrosis loses salt in the skin. The sweat is like high, high, high levels of sodium. This is a child that you're going to give them a salt shaker. They lose salt like crazy, okay? So that's at birth. Now, later on, what you might see all of that, respiratory and lungs and filling up, or we might see a lot of stools that are, just they're foul smelling, greasy. They're not absorbing any of their fat. And again, these children, because of breathing and problems in nutrition and absorption, poor weight gain, right? They're not going to gain weight because they're working so hard to eat. And number two, they not have the proper things to digest their food in them. So we're going to do a sweat test to diagnose those children. So respiratory wise, these children have all of this mucus in their lungs, and it's like having petri dishes waiting for bacteria to go in there and grow, all of these bacterial infections. So these children will require, it's not a when, they will require daily multiple aerosols, especially morning and night, and then in between also. And that is to thin the secretions and to be able to get it up. Now, these children need to get their aerosols before they eat. So we give them their albuterol aerosol, right? And we get their lungs open. Then we're going to do chest CPT. Let's get that mucus up. Once they're done, then they can eat. You can't feed them first and then try to do CPT. They'll vomit all over. And our goal is to be able to get nutrition, so we don't want for that to be gone. Another thing with doing any respiratory care with these children, always be careful to clean the equipment at the end of the day, because that extra mucus and the coughing and the mask, etc. We don't want to contaminate ourselves daily with the same germs. The other treatment is the one with nutrition. So cystic fibrosis has a pancreatic insufficiency, and it does not absorb fat. So you can eat fat, and what happens? Nothing. It doesn't get absorbed, it's not used, and you get these bulky, foul smelling, nasty stools. Fat is the highest calorie of all the nutrition. Fats are 9 calories per gram. Okay. You're talking protein and carbohydrates are only 4. So you can see fats are so important, with giving them calories. So, how do we help the body absorb more fat? Well, we give pancreatic enzymes. Now, they can be powdered or they can be capsules with these little beads in them. Remember, anything in beads, enteric, we never crush those things. The powdered one, especially on younger children, we can sprinkle it on a little bit of food and give it to them. You're not just going to eat powder or put it in liquid. No, put it on a little food and put it in. The thing with powdered, just like we do with asthma patients getting those Symbicort and Brio and Advair, those things, we want to rinse them out because the powder damages the enamel of the teeth. Another thing I think we forget is children grow, and sometimes they grow 10 pounds in 1 year, and we need to increase the dosages. I think I see this a lot with seizures, where the kid grew 10 pounds last year and the dosage of the medicine wasn't increased. So, as nurses, always check those things. It's something I got in the habit of doing. So, respiratory management, you want to clear the lungs out before you feed them. You give that bronchodilator medicine. Physical activity is not when you need to be active. It's not a PRN thing. Swimming is a great cystic fibrosis because you hold your breath and go underneath the water. It causes PEEP and helps your lungs expand, right? Also, these children are always having a PICC line and antibiotics. You can also put them in the aerosol. I've seen gentamicin, tobramycin done in an aerosol, and it goes directly into where those germs are. And again, that home antibiotics, they're always with one. So GI. So now we're giving the pancreatase. We're given that opportunity, right, to get the best calories and nutrition we can. So we do those. Now, what sort of diet is this child going to have? Well, they can't have fat. So low fat, high protein, high calorie, and give them a salt shaker because the salt is oozing out in their skin. They also have issues with intestinal problems. So be aware of those sort of things. And they have reflux. So they might need some sort of medicine for that also. Cystic fibrosis is the pancreas has a problem. What else does the pancreas do? Diabetes, right? Insulin. So children that have cystic fibrosis may develop into diabetes as they get older. Okay? Pancreas, diabetes. It can happen, all right? Again, cystic fibrosis, the big thing is the failure to thrive, the nutrition. It's because trying to get calories in this child is really, really difficult. Pregnancy and cystic fibrosis. I told you cystic fibrosis is pretty well covered in this exam. I think there's 5 or 6 slides here. Pregnancy. Now, women can get pregnant, not a problem. High risk pregnancy, but they can get pregnant. Now, a man cannot deliver the sperm to the woman to get her pregnant. There is blocked ducts in the vas deferens from mucus. 1 year after bilateral lung transplant, it is possible for a man to get his wife pregnant, his partner pregnant. That's crazy, isn't it? The vas deferens is clogged. You can't get the sperm. We give them 2 new lungs. Chemically, I don't know what happens, but they can have a baby. And many men do that. Sleep apnea is just like adults, right? That's that snoring, breathing problem. That's why we do TNAs. And we use the machines just like we do with adults. They do the sleep study. We'll do that TNA, put them on some sort of BiPAP. And again, it's just teaching them what's going on. It's the education. Acute respiratory distress syndrome. Children do things at times. Drowning is a big one. Drug overdose when we're getting older in the adolescence, where they've had an episode where their lungs have been injured somehow. The thing about lungs, you don't necessarily see how bad they're going to be initially. It could be up to 3 days later. So a drowning will be admitted to a hospital. If they were out under the water, pull them out, get them breathing. They're running around, they're fine. Up to 3 days later, they can go into acute respiratory distress syndrome, and I'm telling you, they get sick. This is a picture of ECMO, where we take the blood off, put oxygen in it, and we put it back in. I was blessed. I actually took the course and learned how to do it. It's very interesting, that whole concept there. But again, ARDS, sick kid if they make it. Oh, here's your CPR, guys. So again, CPR, don't just remember CPR and the 15 to 2, the 30 to 2. Remember, there's parents, there's family members during this whole thing. I would always make sure that there was a social worker, a nursing supervisor, somebody with that parent. They used to not let the kids come in the room. Can you imagine your child is dying? Would you want to be there holding their hand, knowing that what was done, you did everything they could? Anyway, that's something to think about. Asthma. Now, croup is upper airway swollen, air can't get in. Inspiratory. What happens with asthma? Well, the upper airway is fine. The air gets in and it doesn't want to come out. It is severe expiratory problems, okay? My husband went into severe status asthmaticus. And what happens is they're trying to breathe, they get restless, all that stuff with hypoxia. But when we listen to the lungs, I would listen to every lobe. On the right lower lobe, I heard a, that was it, at the end of a breath. That was the only air that was going through. So, what is asthma? Something happens, there's a responsive, some antigen, allergen, something that was not good and created this, lungs to go crazy. Dogs, cats, could be grass, all different things. So, how do we manage this? Well, those little things up top right, those are what we call a spacer. I think they're awesome. I mean, even adults, it's hard to push it and breathe in. Some adults can't chew and walk, right? So, same thing. Put it, you take and put the thing on the end of it, squirt it in, and you breathe it in one, two, three times, whatever you want, and you got the whole medicine. You'll even see little infants, 2 years old, holding their own things and giving their own medicines. So it's good. Another thing we look at is also, their end peak end expiratory. We used to not have those equipment at home. Nurses didn't even have it. It was like this big thing that the respiratory therapists had. But the thing is, that's telling you when you're not breathing the way you should, that your volume is going down, and that you need to maybe do other aerosols to keep your lungs open to prevent, going into a status type of asthma, right? So, asthma, we give that morning and night, that little light steroid one, and that's for prevention of bronchospasms. We have our rescue, our albuterol, Ventolin, Proventil, whatever you want to call it. And we have corticosteroids. And that's when we're in an acute stage. We need to decrease all of that inflammation. As I said, status asthmaticus, my husband was in it for 12 days. Um, because of me, he never ended up intubated, but he hit that little BiPAP machine with the mask. And he told me it was very hard to let the machine to try to breathe for him. And even that was as scary for it. But status is basically, you don't break that spell, they're not going to breathe and they're going to die. That's basically it. And they put them on max everything. The aerosols, the steroids, aminophylline. I mean, they go on and on until they find out what works. All right, let's do the respiratory now. How's that sound? All right, we're just going to get going. Remember, I don't look at your scores. This is here for you to test yourselves. A majority of upper respiratory infections are caused by what? So, respiratory infections, most of them are viruses. Yes, it could be some of the other things, but every time you take your child into the doctor, upper respiratory problems, he's going to do the culture, the strep test, the flu test. They're negative, he's going to treat you as a virus. You walk into a 6-year old's room and you find them not breathing and does not wake up. What are you going to do? Here's some of your CPR stuff. Okay, so what they say now is to just start chest compressions. And then you're yelling for help, right? It used to be years ago, breaths first and then compressions, but they determined that there was enough oxygen in the blood. Just go ahead, do chest compressions because they found that many people would not do CPR because they didn't want to put their lips on a stranger. So they say it's better just to do CPR and keep them alive. And that's how that changed and why. A multi. What are some signs and symptoms that smaller children may exhibit that have a respiratory infection? What do they look like? So, everything. A kid has a fever. They're not going to want to eat. A lot of them are vomiting, and a lot of them, their tummies hurt. When you start seeing that they look pale and they're sitting in the corner and they're regressing, all of those things are telling you you need to find out what's happening. Is there a fever going on? What's happening? Have they vomited? Have they had diarrhea? A multi. What do you look for when assessing respiratory function? So we want to know how fast, how deep, is it easy or is it labored? Absolutely. What would you look for after a child has a tonsillectomy? So after a tonsillectomy, when you start seeing a child swallowing and swallowing, you need to understand what is it. It could be bleeding back there because remember, it's the back of the throat and they can bleed to the point of swallowing. That is your biggest clue. Now, do they have severe pain? Not really. I mean, I had my tonsils done in my 20s, so I remember it well, but it wasn't horrible pain. You still can drink and you should not have a fever. It's a clean procedure. They shouldn't. And if you do, there's a problem. A multi. Nursing care for a child status post tonsillectomy include. So, tonsillectomies post. We don't want any spicy foods, right? That burns and it hurts. Pain medicine, absolutely, because I mean, and they only use acetaminophen for children. They used to give them a hydrocodone before, but they found just acetaminophen and just making sure they get it on time. And then they'll drink their liquids. Remember, the gum is for those ears on older children. It's like going in the airplane. It hurts and it burns and older kids. I know the young kids won't do it, but the ice actually does help. A multi. What signs and symptoms would you see in a child with otitis media? You don't always get ear infections. You don't always have a fever. That's the one thing with ear infections. Many times there is no fever, but the pain is absolutely there. And because of the pain, you don't want to eat. And if you've ever had an ear infection that now has burst, you have this serous and oozy, yellowish discharge coming out of it with that. I'm multi. What would you suspect if a child has a dry, bothersome cough that keeps them awake at night?
Hmm.
That is called tracheal bronchitis or bronchitis. Okay, asthma is not a dry, bothersome cough. It's a cough with expiratory wheezing. Okay, they're coughing and coughing, expiratory wheezing. That's asthma. And pneumonia, that's a fever, and that is a cough, but it's wet. Remember, there's consolidation. There's something in there that needs to come up, so it's wet. It's not dry. The monthly immunization for RSV is Synagist or Pevizumab. This is one of the ones you need to remember this name. You're going to see it on NCLEX. You're going to see it on your essay. It's one of those names. A 4-year-old child has been taking meds for asthma and they're still wheezing. What information is important? What do you have to ask? They're still wheezing. And the funny thing is, this has happened to me before that you have a young kid that have asthma, they're taking their MDI, but they're not doing it right. So I give them a spacer, let them try it. And now their wheezing gets better. Okay. Again, spacer, adult to child, and you can use them on young kids too. An 8-month old with croup exhibits what signs and symptoms of respiratory distress? So, an 8-month old, what would they look like? What are some numbers that show me distress on an 8-month old? So, heart respiratory rate of 25 is normal. Pulse rate is normal. So, that can't be any respiratory distress. Pulse ox above 92 is perfect. So, that's all right. Heart rate 100 is fine. Now, respiratory distress. I'm showing retractions. I'm getting restless. I'm getting hypoxic. That's the answer. You might see a heart rate of 130, respiratory rate of 40. That would be respiratory distress on an 8-month old. Signs and symptoms of asthma include all except asthma. So this is a tricky question. You're going to have that cough. You're going to be wheezing, shortness of breath, but they have prolonged expiratory phase. Remember my husband trying to get that little squeak out, and that's all. And he worked so hard, all this effort trying to get air out. It would be a little, that would all it be. What should you not do to children diagnosed with croup and epiglottitis? So anything upper airway, you worry about airway, is do not examine it with anything. Tongue depressor, no, leave it alone. Don't make it more swollen because we need to maintain an airway. Nursing interventions with a patient with epiglottitis would include, you have a patient with epiglottitis. So my epiglottis is swollen all over my trachea, which means I really can't breathe. So I got to make sure there's some way I can breathe at the bedside, and that's intubation or a trach tray at bedside. We're not going to suction, that's going to create more problems. And we're not going to have anything to drink. Epiglottitis, I can't breathe, I can't swallow, nothing by mouth on any severe respiratory distress. Adult or child, don't matter. Which triad suggests epiglottitis? Sore throat, can't swallow, and drooling. Very good. A multi. Treatment for infectious mononucleosis, the kissing disease. What's the big thing about a kissing disease? So, infectious mononucleosis is the Epstein-Barr virus. So, no antibiotics. It's antipyretics, fluids, and rest. And because we're worried about the big inflamed lymph nodes like the spleen, no contact sports, or it could burst and the child could die. And I don't ever want to see that again. A multi. When doing an admission on an infant with a low grade fever and a loose cough, what information is important? What do you need to know? You're admitting an infant. They have a fever and a cough. What do I need to know? So I don't really need to know EPGAR scores at birth. I mean, we just need to know, are their immunizations up to date? Because that's going to tell me where I need to place that child. If they haven't had immunizations, they've got to be in a private room with a fever and a cough, okay? I want to know what their fevers have been running. And of course, the medications. When did you last give acetaminophen? When did you last give ibuprofen? So I know when I can give the next dose. How is cystic fibrosis identified? Cystic fibrosis is they sweat salt out of their skin. So they do, of course, that newborn screening. They do that when mommy's pregnant with the baby. But at birth, you're not seeing stools at birth for the first 2 to 3 days. They're going to be doing a sweat test, looking for sodium in the sweat. High levels are telling you it's cystic fibrosis. A multi. What is included in the plan of care for a child with cystic fibrosis? I mean, this is a child who has problems with their lungs. They have a problem with nutrition. They have a problem with losing electrolytes in their skin. I mean, how are we going to take care of this child? Well, we're going to be giving our, aerosol to dilate the lungs, and they're going to do aggressive chest PT before they eat. When they're eating, we're going to have some sort of pancreatic enzymes. If it's the powder, we're going to make sure that we rinse our mouths. It's the crystals and whatnot. We never crust up any anti-tear coated anything. And it's high protein, high carbohydrate, high sodium. They're losing salt like crazy in their sweat. They need salt. What medication would you hold for an infant that is vomiting and vital signs are 98, 88, 32? What medication would cause those vital signs and vomiting? And all of those medications can be given to an infant. There's not like special cardiac meds, it's just pediatric dosing. So, vomiting, heart rate 88, that's digoxin. What does digoxin do? It slows and strengthens the force of contraction. So, if we're vomiting, that's showing you this is probably dig toxicity. In fact, that might be the only thing they show you is vomiting, and maybe their heart rate has gone a little bit lower. What should you do? Hold the dose, call the doctor, get a digoxin level drawn before I would give it. Which information is most important when rheumatic fever is suspected? We're going to go over this in the cardiac area. I'm just starting to mention it now. So, rheumatic fever is caused by a strep infection that wasn't treated or not completely treated. I'm going to go into more of all the signs and symptoms when we get to the cardiac. That's just an introduction to it. Signs of shock in children include all of the following except shock. Everything but what? So, shock, you're going to have elevated heart rate, decreased blood pressure, decreased urine output, decreased prolonged capillary refill. You're going to be, confused, not hypertension, because shock is when you lose your blood pressure. So it'd be hypotension. Which of the following is the most common cause of shock in infants and children? So, children, just think about it. Children are just starting to get into the world and getting used to all the germs and bacterias and viruses out there. They don't know how to tolerate it. So, the most common is infections. Their body doesn't know how to handle it. They don't have the oomph yet in it in order to be able to fight it. So, most common cause of shock? Absolutely infections. Septic shock is another word for it. A multi. Signs and symptoms of rheumatic fever include you can guess this one, but you're going to remember it. It's rheumatic fever. It's that strep infection that wasn't completely healed. And what happens is a couple weeks later, all of a sudden, these children come in to get medical treatment because they have this, what we call chorea, which is they got movements and they can't control the way that their hands and their body's moving. Okay. They also get these nodules, this polyarthritis sort of thing. They also get heart valve damage. Now, in rheumatic fever, everything can be reversed, but we have to treat the strep. So it's long-term antibiotics for the strep. Now, everything can be turned around. The chorea, those movements, central nervous system stuff, the joints, the polyarthritis, all of that can be turned around to baseline, except if your heart valve was damaged, It is damaged, and that's the mitral valve that it hits. And it could be medically or surgically treated at that point. A child just had abdominal surgery and cannot cough well enough to expectorate secretions. What is the nurse's priority? How are you going to make them cough well enough to expectorate? Because we know post-op, they have to. You have to prevent all those complications, right? DVTs, respiratory complications. So if we medicate for pain, this child is going to be more apt to get up, get out of bed, take deep breaths, and cough, whether they're adult or children. Now, children are not going to ask you for pain medicine. Adults will. They will not. So again, make sure that they get their medicine so that we can get them up and moving. So an infant of 3 months has a fever of 103.6. What would you medicate the infant with? Child has a fever. He's 3 months old. What are you going to give him? Only Tylenol, only acetaminophen until they are 6 months old. There is something to do with platelet coagulopathy sort of things with children, infants less than 6 months. And that's why we don't give anything but acetaminophen for the first 6 months of life. Another multi. A critically ill child is on complete bed rest. What can a nurse do to prevent complications? We think of kids and children, and we don't ever think that they're going to be so sick that they're going to get all of these type of, complications that old people get, right? But yes, they do. They get bed sores, they get foot drop, they get all of those things. So, what do we need to do? We need to prevent it. And how do we do it? Well, let's keep their lungs going by using incentive spirometry. You don't want any sort of diaper quote rash, whether they're adult, bigger children, but you don't want any excoriation. Possibility is the decubitus anywhere. So keep them dry. Diapers, chucks, towels, whatever it is, but keep it dry. Another thing is using those pillows and blankets to keep them turned over. In children, I would use Beanie Babies to hold their ET tubes, and they would look and they could see their little Beanie Baby, whatever it was. Or I'd have them hugging at one of their stuffy toys, like a teddy bear, or in between their leg. It's soft, it's mushy, and then they're hugging it, and the baby looks cute, and the parents like it. So whatever you do is to prop them up so they stay over on their side or wherever you want them to be. How can oxygen be delivered that is the easiest tolerated and accurately monitored for infants? Infants, one of the biggest complications at birth is respiratory distress, TTN, transient tachypnea of the newborn, right? So we need to give some oxygen. And how do we do it? The best way is actually the oxyhood. An oxyhood is a clear plastic dome, and it's got a little thing here for the neck to sit in. The child can look around, put his hands up, suck on his fingers, suck on a pacifier, and we can accurately monitor the percentage of oxygen that goes in there. So it is a great, great thing. Plus, you like to see the kids with his eyes open looking around. The parents like it. A multi. What procedure are used to keep the lungs open with a child with cystic fibrosis? So deep breathe, chest CPT, exercise, and it's not a PRN ambulation. It's QID, TID, it's ambulate frequently. Again, we want to keep those lungs open and moving. And last question, a multi. Children with cystic fibrosis require pancreatic enzymes with meals. What teaching should be done? So, right before the meals, if it's the capsules, you can open them up, but we never break up those capsules because the enteric coated, we just don't. Again, as they grow, make sure that we increase the dosage and rinse the mouth if it's powdered. Let's see how we did on respiratory today. Number 3 is a KJ. Good job, a KJ. Number 2, an AK. AJ, AK. And number 1, Susan. Thank you, Susan. Good job. And a Natalie. All right, we're going to go on and we're going to do cardiac now. I think cardiac scares a lot of y'all. But I'm going to try to make it in a manner that is a little bit more understandable for you, okay? Stephen, are you there, my dear? Stephen Wangangi? I don't know how to say that name, sorry. Thank you, my darling. Just come on camera. Did I say your name and destroy it completely? I apologize. All right. Let's look at our hearts. So, when we talk about hearts, we always talk about lungs, don't we? Because the heart takes the blood, puts it in the lungs, oxygenated, and it goes to the body, right? So the first thing I want you to do is I want you to go back and look at your anatomy, all right? Because I'll be mentioning some valve names and some structures. Now, children and adults, there's different sort of cardiac defects. There's some that you're born with, those are called congenital. And then there's some that, with whatever happens to the body, infection, autoimmune, environmental, the familiar sort of things, that they're acquired. We mostly talk about congenital defects when we talk about children. This is the picture right out of your book. I'm going to go over briefly so I can, give you some words and see if you can follow me as we go on further. So let's start with the right atrium. So blood just gets back to the heart, into the right atrium. It goes down through the tricuspid valve into the right ventricle. Then it goes up the pulmonary valve into the pulmonary artery and into the lungs, and it gets all oxygenated. It goes back to the heart in the left atrium, down the mitral valve. That's the one that rheumatic fever can, destroy it, and injure it. And then it goes into the left ventricle, up the aortic valve, up the aorta, and to the body. Now, I'm going to mention a condition right here, and let's see if you can follow me. So, up off that left ventricle, up off the aortic arch, the aorta, right? Let's put a kink right after the 3 that go up the subclavian to the upper head, right? Let's put a kink in the hose. Let's put a narrowing in it. Let's think about a garden hose. What happens when you kink a hose? Behind it, if there's a hole, an opening, it's going to squirt that way because it has to go somewhere, right? So if the aorta gets a kink or a narrowing in it, we call that what we call a coarctation of the aorta. It's a kink in the hose in the aorta. So let's think. Let's look about pressures and what happens, a garden hose. So, all right, that blood cannot go down anymore, or a little bit littler because that it's narrowed. Blood can't go through the aorta because it's kinked, it's narrowed. So blood going down can't get there, or minimally, which means blood pressures, pulses, lower extremity are going to be decreased. But the blood has to go somewhere, so it goes back. So let's go backwards. It goes back into the left ventricle, left atrium, and it goes back and it fills up the lungs. So now coarctation causes decreased blood pressures in lower extremities. Therefore, the upper extremities has to be increased because that's where all the pressure is. right? And we're going to see backwards, we're going to see the lungs filling up with fluid. That is coarctation of the aorta. So, children, that little coarctation of the aorta is a very, very good place to start teaching you about your cardiac congenital child. So, let's take that diagnosis. Coarctation of the aorta. Little 3-month-old girl came from the West Coast, and they didn't know what was going on. And she had these symptoms. She was poor feeding. She was tachypnic, tachycardic. She didn't gain weight. She was failure to thrive. She was very small. She had activity intolerance. She couldn't breathe, right? She's developmental delays. She's not getting nutrition. She's not getting oxygen. Developmental delays are part of it. And there was not any prenatal history with this child, and there actually was no history of cardiac disease. But on examination, what would a coarctation of the aorta show you? Very simply, what's the first thing? Let's feel those pedal pulses. Are they there? And usually they're not at all or so minimal. So the next thing, what am I going to do? I'm going to take a 4-extremity blood pressure. Let's measure the upper and the lower pressures, because the lower blood pressures are going to be lower, and the higher, the upper extremities are going to be higher. So, what would be a great nursing diagnosis here? Poor weight gain, right? Because they're tired, they can't eat right, because their heart's working hard, because the aorta is kinked. I'm not getting blood where it needs to go. My lungs are filling up with fluid. So inadequate oxygen perfusion leading to activity intolerance, resulting in diminished energy to breastfeed. So they can't breathe, they're not eating, and they're having cognitive delays, nutritional delays, failure to gain weight, et cetera, et cetera. So looking at these children, we're going to just look at their nutritional status. Are they at a weight that they should be, or are they too little? Their color, are they going to be pink? They'll probably be more purple, right? Because there's going to be a little bit lower. We're going to look, we can actually feel the chest sometimes with these murmurs. And as we get older, you will see clubbing of fingers. That's not as the early children. When we look at the chest, we're going to be looking at, the chest, the abdomen, the pulses, the heart rate. Are they a normal heart rate? Is it tachycardia? Is it bradycardia? Heart sounds. Is there a murmur in there? Is it a regular or irregular heartbeat? So, what we do with these children when we suspect something, first of all, we just stick them on an EKG and see what's happening. And we're just going to do that 12 lead EKG, see if there's any things that we can see there. Then we will do at the bedside, usually right after admission, they do it. They'll do an echocardiogram. And the echocardiogram is going to be telling us, is there any sort of irregularities in blood flow or structure? And if we see anything, that child will be prepared to go for a cardiac catheterization. Now, the cardiac catheterization is going to be able to determine and give a really good diagnosis of that child. We'll be able to see, is it, a coarctation? Is it a tetralogy of Fallot? Is it something else that's going on there? And that's just basically to diagnose it. Interventional, we use those actually with those EP studies, electrophysiology studies. We use those sometimes when we see weird heartbeats. In interventional, we can actually correct tachydysrhythmias and stuff just with a cardiac cath. So, a cardiac cath, you need to know how to take care of these children pre and post. So before the procedure, most of these children will feed up to about 2 hours prior to the procedure. We don't let infants, young infants, be too long without food. They don't tolerate being without sugar that long, okay? So that's what we would do for them. After the procedure, they insert 2 catheters into the right femoral artery and vein. So big catheters that are put in there. Post procedure, my first thing I always check is the dressing. Now, on infants, they'll have a nice pressure dressing and they'll put, some sort of weight on there, sandbag or something, because they can bleed very quickly. And these are big lumen sized veins and vessels that can bleed and bleed out a lot of blood quickly. So the first thing I'm going to do is making sure that it is intact and no bleeding. I'm going to be looking at the pulses. What are the pulses like? It's not uncommon for that right leg where those catheters been placed to have slightly decreased pulses. It's normal for that to happen, but document it so the next nurse knows exactly what you felt, when you took those pulses. And of course, we're going to get some sort of fluid in that child. And we always will check blood glucose. Again, remember, they don't tolerate low glucoses. Another thing is sometimes they put sugar in one of their IVs that they're given, and sometimes their blood sugars go too high. So again, we watch it. So biggest risk is the hemorrhage. Again, that's why I check that dressing first. So congenital heart disease, it's more common than I ever thought it could be. The most common of all the conditions is something called a ventricular septal defect. That is, there is four chambers of a heart. In between the chamber is a septum. So the two bottoms are both ventricles. So it's a hole between the two, a ventricular septal defect. It could be small, medium, or large, depending on it, depends on the treatment. One of the big common associated abnormalities of congenital heart disease with VSD is also congenital trisomy 18, 13, 15, 21. Now, usually when we think of trisomy, we think of Downs, we think of trisomy 18 or 21, correct? I've actually seen a 9, an 11, and a 15. And the difference, as the number gets littler, there is more defects, more severe congenital anomalies. Actually, the one that had a 9 had one eye, had a half a heart, and could not live off of a ventilator. That was a trisomy 9. So we usually think of the 18 and 21, and they're cognitively delayed, and we just have to give them early intervention and try to catch them up and have them be as best as they can be. Now, I sort of mentioned it about shunting when we talked about mucus in ears and ear canals, right? Well, let's go to the heart. There are pressure that's high and pressure that are low in the heart. Let's go back and look at this. Very simple. Blood goes from the lungs into the left side of the heart with 4 pulmonary veins. There's not one, there's actually 4. So there's high pressure. And then you got that left ventricle pressuring, pumping out blood. So the left side is big, big pressure. The right side of the heart just gets the blood back after that one beat, right? So the pressure coming in is low. So where do you think blood would like to go from? High pressure to low pressure. Remember at birth, in the right atrium, left atrium, there's that little patent foramen ovale. It's that little extra little hole at birth that's there. You know what happens? The blood comes down the left side and it will shunt over to the right side. And if it's a bigger hole, like an atrial septal defect, definitely blood's going to go left side to right side. It's almost across the board, left side to right side. So here are, again, it's out of the book. It's a great depiction of your type of hearts. And you notice they are broken out by acyanotic and cyanotic. Acyanotic means your blood flow is good. That means your oxygen is good. Those are basically connections between things, but oxygen is able to be there. That's your ASD, that's your VSD. I'm going to go into the PDA in a little bit. It's more involved. And look, obstruction and still acyanotic coarctation of the aorta. We're still getting blood to the lungs and to the body. The cyanotic side, the one that you really need to know, and it's what the one it's always tested on, is decreased pulmonary blood flow or tetralogy of the low. Have you ever heard of something called a tet spell, a blue baby? What happens is the pulmonary artery, which is that comes from the right ventricle, the pulmonary artery gets that blood to the lungs. And what happens is that pulmonary artery spasms, closes up, and blood can't get to the lungs. Now, I had this happen to me one time. It was 4 or 5 in the morning, and I had O2 saturations of 100%. I went in and just changed the diaper and wiped the mouth and combed the hair, made the baby look pretty. And the kid went into a TET spell. He went from O2 sats of 100, he went to 10 in about 30 seconds. He went from pink to black. So, how do you, as a nurse, and what you can do for a tetralogy and a blue spell? You take their knees and you push them quickly, briskly up to their chest. So you pull their knees up. Older kids actually sit and squat. They just know what to do by themselves. They just know, and that's what happens. So tetralogy, blue spell, right side of the heart. And there's 4 conditions with it, and we'll go over that in a second. Now, mixed blood flow, what you need to know is transposition of the great arteries. So off the heart, you have a pulmonary artery and you have an aorta, right? We have the right side goes to the lungs and the left side goes to the body. Well, I don't know why, and I've seen quite a few of them. The pulmonary artery and the aorta are switched. So we have oxygen, blood here, unoxygenated there, and there's no mixing. So the baby's not getting oxygen. So when a baby is born, when the baby's in mommy, they get oxygen through a fetal circulation, right? You were taught that. And it's through something called a patent ductus arteriosus. It's a connection that closes at birth because you don't need it once the baby's outside. But if you have transposition of the great arteries, you still need to get oxygen to where it needs to go. So we need to keep that patent ductus arteriosus open. What is that? What is a PDA? Well, we know that you're hypoxic when the pulmonary artery and the aorta, oxygen and no oxygen, they don't connect. So we need to connect them. And that is the patent ductus arteriosus. It connects the aorta to the pulmonary artery. So it gives lungs with oxygen, it will go to the body. We're going to go over that a couple more times. So PDA, it connects the pulmonary artery to the aorta. It is fetal circulation. We have it at birth. It's there. Every kid has it. Mommy produces something in her body, a hormone called prostaglandins. And this keeps this duct open. So at birth, mommy goes away, and so does the prostaglandins. So this duct closes. At birth, you hear a loud washer machine murmur. And you can hear it. It sounds like a washer machine going on. Another thing with a PDA is their blood pressures. You can tell when one is still open. Their numbers are far apart. You can see it here, 60 over 18. A normal pressure, 60 over 40. So as that starts to close, guess what? That diastolic number will come back up to where it should be. So prostaglandins keeps the PDA open. Now, PDA's there, we need to keep it open because we have transposition going on. So we put a slow, continuous infusion. It's not an IMPO, no, it's a slow, continuous IV infusion. And this prostaglandins maintains oxygen saturations. It keeps the lungs, the pulmonary artery, and the aorta. So lungs and the body are connected. The body's now getting oxygen and it helps cardiac output. Now, sometimes this thing keeps open and we don't need it. We don't need it. The heart's fine. Everything's good. You see a lot of this in premature infants, believe it or not. The little, like this 27, 28 weekers. You always see PDAs that don't close. So we can close it two ways. We can do it with a medication or surgery, but of course, we prefer to do a medication. There's actually an NSAID, believe it or not, IV NSAID called indomethacin. Years ago, they used to give this pill for back pain, like an ibuprofen. Before ibuprofen, it was indomethacin. So when I heard we give this IV, I'm like, huh? But it does, it works. It's 3 doses and they monitor it very slowly, but you can hear that murmur close. And I used to love to watch the blood pressure, the diastolic number come back to normal. And then I know it would be closing. There's a couple slides here that go into increased pulmonary blood flow. We know that any hole connecting to the right and left side, we're always going to go from the oxygenated side. The left will always go to the right, ASD, VSD. And there's just more flows to show you. Now, congestive heart failure. I've mentioned this when we talked about coarctation of the aorta, right? Not uncommon. Get a kid with a congenital heart defect whose heart is already hard, not beating that well. A lot of times the heart will fail. What happens? Well, when the heart doesn't beat the way it should, it doesn't squeeze the way it should, and blood will go up into the lungs and will sit there and fill up with fluids. You will see an x-ray that's all fluffy and full of all sorts of fluid that's going on in there. You might see O2 sats coming down. So what do we need to do for a child in congestive heart failure? We've got a lot of extra fluids, and we're going to see a sudden weight gain. That's usually part of looking at a child with congenital congestive heart failure. All of a sudden, they're gaining weight, they're getting more tachypnic, they're tiring easy when they're eating. This is showing you something's going on. So we have to make sure we improve that cardiac function so that it's beating slow and more effectively. They might be placed on digoxin or another medication to help that heart. Removing any fluid sodium, diuretics, right? Furosemide, not uncommon for brand new infants to be on it. And then decreasing cardiac demands. Children in congestive heart failure still need to eat, right? So we're going to give small, more frequent meals, and we are going to limit their eating for no more than 30 minutes, right? And give them that good calories in there. So, as I said, sometimes we do give digoxin. How do you give digoxin? And then I'll say, how do you give it to an adult? It's the same thing. It's just a different size child or adult, right? So count the apical pulse for a minute. You have to know what normal heart rates are. That's why I gave you out a guide. No, it's not a perfect guide. The numbers aren't perfect, but you understand that the numbers come down for heart rate as they get older. Blood pressures go up as they get older. And that's what I wanted to do by giving you that form there. We will be checking the potassium. If it's low, I don't want to go into dig toxicity. Checking a dig level, same numbers, just because they're adult or child, it's the same values, 0.5, right? And the one thing, as I said, you only may see a child vomiting. It may be the only thing you see. So if a kid doesn't vomit and they're vomiting and they're on digoxin, it's better to be safe. hold the dose, call the doctor, get your ditch level. So we want to keep that kid, quiet, decrease cardiac demands, respiratory distress, keep them calm. And again, nutrition. You got to keep nutrition, cognition. They need that. And we're going to be monitoring daily weights, intake, output. Very, very important. Hypoxemia, very common with one of the conditions, the most severe of all cardiacs, is called a left ventricular hypertrophy. You've got a hypoplastic left heart where that ventricle is thickened and the inside is so small and you can't pump any blood. And these children normally have O2 sats 65 to 75 at birth. And we're going to keep it there. Okay. So these children, one of the things that we're going to see is what we call polycythemia. So, why is that? You have a body that does not have good oxygen. The body says, okay, red blood cells carry oxygen. Let me produce more so we can have more oxygen. So that's polycythemia. Hemoglobin hematocrit, instead of being 12, are now 18 and 19. I mean, it goes that high because the body's trying to produce cells because that's where the oxygen should be coming from. So that's what that means. I have to tell you, cardiac families are probably the nicest of all the families. They really want to know what's going on. They really want to be taught. So educating the family and the children, very important. And we know discharge starts from admission and teaching them. I've already talked about cardiac cath. Bacterial endocarditis. It's something that can happen even in children. Again, just like adults, there's going to be prophylaxis before procedures, dental procedures, surgeries, or anything. And here we are, that rheumatic fever that we hit already once, but here, let's go into it at depth. Rheumatic fever is due to a strep infection that was undertreated or not treated at all. These children, it affects joints, skin, brain, serous surfaces, and the heart. And as I said, the one thing that cannot be reversed is that heart valve damage, which is the mitral valve. So a kid comes in having these weird movements, these polyarthritis, sore throat, aches and pains. We're going to be doing, an anti-streptolysin test. It's an ASO test, and that's going to show the strep in the blood. And we're going to be placing them on long-term antibiotics. Could be a month or two until it's gone. And again, everything goes away except for that heart valve. Children can get high cholesterol. We didn't test this for many years, but we're finding that they do, and we need to be looking at it. Children can have dysrhythmias, all type. I think the smallest child I saw with a pacemaker was 18 months old. Brady dysrhythmias, little tiny, little itsy bitsy, and they put it in the abdomen, not in the upper chest. Pulmonary artery hypertension. This is when the lungs get hurt and damaged and they go in spasms and they close up and they're protecting themselves. But what happens is now with any sort of exertion, they get tired easily because they can't exchange oxygen and carbon dioxide. So they get the chest pain, they get dizzy, and of course, the shortness of breath. Cardiomyopathy. It's another one of the things that I've seen that it usually leads up to a transplant, but these kids come in with these big stretchy hearts and they come in what we call for tune-ups, and we put them on some Primacor and some Dig, and we get their heart doing a little bit better and send them home. But again, there's just so much tune-ups that can be done. It could be due to viral infections. Actually, cardiomyopathy can happen. It could be some sort of nutrition, but just think about lupus. Lupus can attack a heart, right? It can attack anything. So again, heart transplant is usually the outcome for that. And know that rejection Not infection. Rejection is the largest reason for death. Chest tubes, not uncommon in children that are going to have cardiac surgery. They could put one in, and I've seen up to five chest tubes, depending on the child, even infants, three, four of them in there. And it's just to keep that chest cavity nice and clean and open so the heart can beat the way it can. Now, the one thing that we need to remember is chest tubes, when they're removed, it burns intensely. Now, I'm actually sort of lucky because I've also worked adult open heart surgery, and I worked the night shift, which meant every morning at 6 a.m., the surgical residents came around and removed all the chest tubes. So I talked to a lot of adults getting chest tubes out, and they tell me it's intense burning. So, number one, please, priority, medicate for pain. And then, of course, explain to the child on their developmental level what you're going to do. And you're going to hear me say this again and again. Be honest. If it's going to hurt, tell them. But tell them you'll do everything possible to make it as little as pain as you can. Hypertension. I used to not take blood pressures until children were 5. Now we're doing blood pressures on all age children. Again, we're finding high blood pressure on little kids. Kawasaki disease, very interesting thing. Kawasaki is a acute systemic vascularitis of unknown cause. I think it's a viral type thing. Okay, again, a vascularitis, inflammation of the vessels, and they inflame, and micro emboli can be thrown around there. Okay. The problem with Kawasaki is that it can go and attack the coronary arteries and cause aneurysms. That's the big deal with systemic Kawasaki. So what do we see? I think the most notable thing is eyes, big red glow in the dark eyes. They look like they're really drunk or something. I mean, they're really red. And then look at the lips and the tongue, strawberry tongue cracked. The hands and the soles of the feet peeling, blistering. This is normal that we would see. So usually they've had an upper respiratory, and then all of a sudden they start with this. Now, again, our biggest concern is that coronary artery aneurysm rupture. That's our biggest concern. So, treatment. We're going to be given intravenous gamma globulins, IVIG. So let's boost their immune system. Again, it's a virus type thing. And we're going to be having them on high dose aspirin. They sometimes will do, Coumadin, an anticoagulant instead, but usually children, high dose aspirin. Why do they put them on aspirin? Well, vascularitis, little microembolus. We're talking coronary artery. We want to thin the blood, prevent clots. That's why we do it. COVID, we've lived it, right? Look at that. Treatment is similar to Kawasaki. Again, it's IVIG, isn't it? Shock. I told you the most common is septic shock. And anaphylaxis. Children could be the first time you give them an antibiotic. Remember, newborn infants have never had any medicine. You might be giving them a dose the first time, and they could go anaphylactic. Again, we're going to do the same treatment as adults. Get out the epi, get out the Benadryl, get the Solumadrol, and watch the airway. As I said, septic shock, toxic shock, children, your adolescents, this could be the tampons. And surgical closure of the PDA would result in which of the following? PDA connects the aorta to the pulmonary artery, which gives oxygen to the body. So you're going to close it. What's it going to do?
If you're closing that duct, would it be A?
Yes, ma'am. Good job. So the PDA is a big thing. Prostaglandins, indomethacin, these are words you need to know. Digoxin, how to give them. So who would like to try to win this Kahoot? This is a harder one. There's only 21 of these questions, so we're doing good. Again, remember, I've given you a great matching handout sheet. And if you know what those things are and you can work them back and forth, what works with this? If you don't have this, what would this do? You'll be okay. Nobody else wants to join me. Nobody wants to win. Thank you. All right, we'll go ahead. Cardiology. I worked in cardiology, my favorite place I ever worked. Why would a child with tetralogy of Fallot not gain weight at a normal rate? Tetralogy of Fallot, congenital heart, cyanotic, the most common and the most tested in all of your exams. So tetralogy of Fallot, I'm not getting oxygen, right? So I'm not getting oxygen, I can't eat. I have no energy. Very good. A multi. A clinical manifestation of Kawasaki disease is when I was working in the cardiac ICU, the director's son at age 3 was admitted one night when I was working with Kawasaki disease. Big red eyeballs. I'll never forget it. Can you imagine your director here? Betty, you're going to take care of my kid? I'm like, oh, okay, sure. Blistered, cracked soles of feet, hands, palms of hands, strawberry tongue, the lips, the reddened eyes. Perea is not here. It's rheumatic fever, okay? Try to keep them straight. Which of the following best describes the pathophysiology of Kawasaki disease? So remember, it's a vascularitis, that inflammation which causes little microembolus, and we're worried about the coronary arteries. That's the big thing. What is the treatment for Kawasaki? Aspirin and IVIG. Remember, it is a virus. It's not a bacteria. So it is aspirin and IVIG. Let's boost the immune system. A multi. Why do you give aspirin to a child with Kawasaki? What does aspirin do? So, pain relief. I mean, Kawasaki, the kids don't really have pain. Okay. It is to prevent clots. Remember, it is an NSAID, so it is an anti inflammatory. And the big thing is that thinning the blood is the big deal. An abnormal hole between the right and left atrium is called what? And it's an atrial septal defect. Remember, when we're talking a hole between atriums or ventricles, what's between them? It's a septum. The septum separates them. So atrial septal is the top, ventricular septal is the bottom. What is the treatment for a TET spell? What did I do when that kid went from 100 to 10? So again, it's knee to chest. Older kids will squat all the way by themselves. And another thing, it's not mentioned a lot, but yes, you should try to calm the child down because again, all of a sudden they're hypoxic. They're getting restless and anxious, right? So trying to calm them, getting them squatting down. Multi. Why is prostaglandins given to a child with transposition of the great arteries? What is prostaglandins? When did you hear about that? Transposition of the great arteries is when the aorta and the pulmonary artery are switched. You don't have oxygen anywhere. So, prostaglandins is what mommy has, a hormone, but we have a synthetic one we can use, and it helps keep that PDA open, which keeps giving oxygen from the lungs, giving it to the body through the aorta. What is the purpose of giving indomethacin to a neonate with a patent ductus arteriosus? What does indomethacin do? Prostaglandins does what? Indomethacin does what? So indomethacin basically closes the PDA. It blocks the prostaglandins, doesn't allow it to keep it open, and it just closes it. How do you know the PDA is closing? The blood pressure changes, right? And that murmur you start to hear is going to go away. Very good. Transposition of the great arteries is so transpositions, the great arteries, what are they? An aorta and a pulmonary artery. They're just switched. That's all it means. Very good. When measuring for blood pressure on four extremities of a child with coarctation of the aorta, you would expect what? What would you see with coarctation of the aorta? Blood pressures. Remember, the coarctation is a kink in the aorta as it comes off the heart. So it kinks and it doesn't let blood go down to the lower extremities. Therefore, lower blood pressures are lower and uppers are higher because blood goes up. Early signs of heart failure in infants include when you start seeing them, they can't eat and they're sweating. It's like they're running a mile, just trying to eat. They're telling you they're in trouble. And then heart failure would be the tachypnea and tachycardia and the sweating, and they're not gaining weight. Yes, you would be able to tell. A multi. Signs of heart failure in a 3-week old with congenital heart disease. So when we have heart failure, you're going to have weight gain. right? Your heart's not working, fluid fills up in the lungs. So it's going to be a weight gain. Also, cool extremities because you're not going to have all that perfusion going on. But very good. Good job, guys. A multi. Feeding the infant with heart failure. So, when you have a child that has heart failure, which means there's fluid in the lungs, which means they're having a hard time just breathing, without eating at all, right? So, let's put them upright so that their diaphragm's down. They have a better chance of breathing good. If they can't eat it all, we can lavage the rest as long as they're getting their nutrition. The other thing is take the calorie count in the formula. Usually it's 20 calories per ounce. Your Similac and Famil, they're all 20 calories per ounce. You can go up to 30 calories or more. So they're drinking less liquid, okay? More calories per each bite, which is what we want to do. And we know heart failure, they're going to be tachypnic, they're going to be diaphoretic, and they can be vomiting. After a heart transplant, what's the leading reason children die? Rejection. Remember that. Rejection. They say, I don't like this one. Get it out of me. Nursing care following a cardiac catheterization. So remember, they got these two big catheters were in that right femoral artery and vein. And they come back to your room. And the first one always I'm going to check is that insertion site, checking for bleeding or a hematoma. Okay. You need to slowly, you can elevate the head of the bed, but that's not your first priority. That right leg, it needs to be kept straight. They need to be on 24-hour bed rest because they don't want to pop the clot off because they will bleed all over. So 24 hours bed rest. Where is the patent ductus arteriosus? So, patent ductus arteriosus, think about fetal circulation. Fetal circulation, what are you worried about? Getting oxygen to the baby. So, it is the aorta and the pulmonary artery, systemic and pulmonary. Those are your two ones you need to remember. A multi. What is a sign of digitoxicity in infants? So the big thing is that nausea or vomiting and the decreased heart rate. Yellow spots. Is the infant going to tell you they have yellow spots? It's going to be the older people. They're going to see those yellow spots. And digoxin has nothing to do with infection. What are the signs and symptoms of heart failure in children? It's a little short of breath, fluid, palpitations, yes. Which medicine is commonly used to relieve the spasms during TET spells? Got a kid whose pulmonary artery spasms tight, your knee chesting them, and we're not popping it open and we're not getting oxygen. What are we going to do now? And what we'll do is we'll give morphine. Believe it or not, morphine will relax them, it will relax the pulmonary artery, and will allow blood to flow. The other thing that they do, more of a common daily thing, is digoxin. So digoxin on a tetralogy patient is not uncommon. Remember, indomethacin closes that patent ductus arteriosus. And last question, key to preventing post-op complications? So again, it's that preventing things, and that's early ambulation, coughing, and deep breathing. And we do that, yes, by pain management, but it is that early ambulation. Number 3, we have a KS. Good job, KS. We got a W. Good job, W. Number 1, Susan. Susan again. Good job, Susan. And a Natalie and an AJ. All right, we're done with today. Anybody who wants to go over that exam with me, I am willing and able to help you go over it. There, a lot of it was on the theorist and understanding it. So definitely, I'll talk with you. I do have a couple people I'm already meeting with after class today. But anybody who wants to meet with me, send me a message, and I will talk to you and help you understand those things. Know that this week you do have your first case study. You have to read it. Okay, that's the thing. There's really no shortcuts through it. You've got to read it in order to answer it properly, because that's where your answers come from all your reading. Any questions, anybody? Bye, guys. Have a great day.